Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is angina syndrome and mimickers of acute myocardial infarction. Here mimickers means ECG patterns which can be easily confused for acute myocardial infarction. Differentiating them from acute MI is necessary for proper treatment. Angina syndrome consists of three entities: chronic stable angina, unstable angina, and Prinzmetal angina. Clinical features in each of these are similar and present with chest pain, sweating, uneasiness, palpitation, etc. There is separate video on unstable angina on this channel. Let's discuss about chronic stable angina and Prinzmetal angina. In chronic stable angina, chest pain occurs on fixed amount of efforts. It is associated with organic stenosis of coronary, but there is no component of vasospasm or thrombosis. Chronic stable angina is also called as Heberden's angina. In chronic stable angina, fixed amount of efforts will induce tall symmetrical T wave or symmetrical T wave inversion or ST depression on ECG. Prinzmetal angina or variant angina occurs due to transient vasospasm of coronaries. Episodes are recurrent and does not have correlation with physical activity. Episodes can be triggered by exposure to cold or other stressors. It can be associated with vasospastic conditions like migraine headache and Raynaud's phenomenon. ECG changes are transient ST elevation. Coronary angiography may demonstrate arterial spasm. It is treated with arterial dilators like calcium channel blockers, nitrates, etc. Benign early repolarization is the most common normal ECG variant which can be confused with acute MI. It can be seen in about 1% of population. J point is elevated maximally in the mid-precordial leads, that is lead V2 to V5. It is seen rarely in limb leads. There are few key features which differentiate benign early repolarization from ST elevation MI. In BER, ST segment is elevated with concavity upward, while in STEMI, ST segment is elevated with convexity upward. In BER, T wave is always upright, while in STEMI, T wave is upright and tall in hyperacute phase, but inverted in evolved phase. J wave can be associated with BER, while reciprocal changes, that is ST depression in distant leads, are present in STEMI. ST-T ratio is obtained by dividing height of ST segment measured from J point by T wave amplitude in lead V6. In BER, ST-T ratio is less than 0.25, while in STEMI, ST-T ratio is more than 0.25. BER is usually associated with good R-wave progression, while old anterior wall MI can cause poor R-wave progression. There are ST elevation in lead 2, 3, AVF, lead V5 and V6. But this ST elevation has concavity upward with J point elevated. If look closely, there are small positive deflection just after J point, which are nothing but J waves. In lead V6, ST elevation at J point is 1 mm, while T wave amplitude is 3 mm. So ST-T ratio is more than 0.25. T waves are upright, there are no reciprocal changes, there is good R-wave progression. So except for ST-T ratio, all features points toward benign early repolarization. But still, this patient should be evaluated further if clinical features are classical of MI. Takotsubo Cardiomyopathy or broken heart syndrome is also called as stress cardiomyopathy because it is induced by catecholamines released during stress. Symptoms are chest pain, uneasiness, palpitation, sweating, etc. ECG shows ST elevation in precordial leads. Cardiac biomarkers like troponins and CPK-Mb are also raised. Even echocardiography shows mid and apical wall hypo or akinesia. All these features makes confusion with acute MI very likely. Only differentiating feature from acute MI is normal coronaries on angiography. Normally, whole ventricles contract, but in broken heart syndrome, mid and apical wall are hypo or akinetic. Because of this abnormal contraction, on echocardiography, cardiac cavity appears like Takotsubo, which means octopus fishing pot in Japanese. This ECG was taken from patient of stress cardiomyopathy. There is ST elevation in lead V3, V4 and V5. It is very difficult to differentiate stress cardiomyopathy from acute MI on ECG. Therefore, Takotsubo cardiomyopathy should be treated as acute myocardial infarction until coronary angiography demonstrates normal coronaries. Brugada's syndrome is a channelopathy occurring due to defective sodium channel. There is defect in SCN5A gene. Clinical features are usually asymptomatic young age person complaining of syncope. There can be a history of cardiac arrest and nightmares. ST elevation is present in lead V1 to V3. Some patients may have atrial fibrillation also. These patients are prone to develop ventricular tachycardia and ventricular fibrillation. There are three types of ST segment elevation in Brugada's syndrome. In type 1, there is pronounced elevation of J point, Coved-type ST segment and inverted T waves. In type 2, Saddleback ST segment is elevated by more than 0.1 mV, that is more than 1 mm with standard calibration. T waves are positive or biphasic. In type 3, Saddleback ST segment is elevated by less than 0.1 mV, that is less than 1 mm with standard calibration. T waves are positive. There is pronounced J point elevation more than 2 mm from baseline in lead V1, V2 and V3. ST segments are Coved type and T waves are inverted. All these features are classical of Brugada syndrome type 1. Such patients should be advised for implanted cardioverter and defibrillator, as they are prone to sudden cardiac death due to development of ventricular tachycardia and ventricular fibrillation. Acute pericarditis is an inflammation of pericardium. Causes are infectious, autoimmune, uremic, or post-MI, where it is also called as Dressler syndrome. Symptoms are retrosternal chest pain radiating to neck, shoulder and left arm, fever, palpitation, cough, dysphagia, etc. Cardiac biomarker may also be raised. Pericarditis is divided into 4 stages. Stage 1, which is also called as acute pericarditis, is characterized by diffuse concave upward ST elevation, except in lead AVR and V1. T waves are upright in the leads with ST elevation. PR segment deviates opposite to P wave polarity. Stage 2 occurs several days later. It is characterized by return of ST segment to baseline, followed by flattening of T wave. Stage 3 is characterized by T wave inversion without Q wave formation. Stage 4 occurs weeks to months later. It is characterized by return of pre-pericarditis baseline features. In this ECG, there are diffuse concave upward ST elevation. PR segments are below TP segment, hence PR segments can be considered depressed. There is ST depression in lead AVR and V1. As P waves are inverted in these leads, PR segments are elevated. All these features are classical of acute pericarditis. Patient with myocarditis can present with chest pain and ST elevation on ECG. Cardiac biomarkers are also raised significantly. Features that suggest diagnosis of myocarditis are presence of fever and normal coronary angiography. Diagnosis can be confirmed with myocardial biopsy and cardiac MRI. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.